Hey everybody, the red light is on, which means the Doctors In Live with TOA is back. Happy Friday to everybody. I hope you all are enjoying what was September. What happened to September? It just disappeared. It's already October 1st. We see a smiling young face here. I promised you last time that we were going to introduce you to somebody who I've really been looking forward to coming and joining TOA. This is Nick Shepard, and Dr. Shepard is a spine surgeon who's based in our Rutherford County offices, so in Murfreesboro, Smyrna. And we're going to talk a little bit about spine from his perspective. He's brand new out of training, excellent training background. Looking forward to watching him grow and build spine for the future for TOA in Middle Tennessee. Before we get started, for those of you who are brand new, thanks for joining us. The Doctor Is In is a free-form information, a little bit of fun production that we've been doing now for, gosh, over a year now. And we're trending toward 75 episodes probably pretty soon. And we've enjoyed trying to address your interests regarding musculoskeletal care. For those of you who've been around a long time, Carlos, you are the man. You know that I try to get on a lot of different guests, a lot of different perspectives, a lot of different information, because it's interesting to me. I know it's certainly interesting to you. And so if you have any ideas, any comments, any ideas for an episode, any musculoskeletal problems you'd like to talk about, comment below. We'll try to get the right people to talk about that. Anyway, as with all episodes, while we are both orthopedic surgeons, we are not acting as your orthopedic surgeons today. So this information is strictly that. It's information, maybe a little entertainment and education. We're not giving you medical advice. If you need help with musculoskeletal care, whether that's spine, foot, joint replacement, shoulders, hands, elbows, ankles, whatever, go to TOA.com. That's our website of all websites, which covers everything about TOA, including our physicians, our locations, our services that we offer. All of our locations from Knoxville to Columbia, up and down the state. We have a lot of information on the Media Center with regard to video information. All of our Doctors In episodes are archived there, for example. So go to TOA.com. You can even make an appointment online, which is a pretty cool thing. So without further ado, let's get into this. So we're going to be talking about minimally invasive spine surgery. And I'm just going to be honest with you. This is a technology, a frame of mind in spine surgery that did not exist when I was in training. I've told you guys before, I'm kind of an old guy now. And technologies have really changed. And so this is an exciting new area. It's not going to replace traditional surgery that I initially trained with, but it's definitely an augmentation to what we can do to try to help people. So this is Dr. Nick Shepard. Nick, thanks for being here.
Thank you so much for having me.
Absolutely. So why don't you tell everybody just a little bit about yourself, you know, where you're from, where you trained, what you like to do, all that kind of stuff. Introduce yourself, and then we'll start on your topic.
Fantastic. Well, thank you again for having me on today. Really excited to be here, and thank you for everyone that's tuning in. So a little bit about myself. So my name is Nick Shepard. I am a spine surgeon here at TOA, primarily working in Murfreesboro in the Smyrna area, so in Rutherford County. In terms of my training, so I did a majority of my residency in medical school in New York City. So I went to NYU for residency. And then last year, I just finished up my specialty or subspecialty training in spine surgery, and that was in Rush in Chicago. So after finishing there, I started up here at TOA, and I started in September 1st. So really excited to get going, and really excited to be part of the community here in Middle Tennessee. In terms of my interests, I try to stay very active, and this seemed like a great place to do it. You have the Smokies right nearby, and a lot of opportunities to get outdoors, fishing, hiking, golfing. And I moved here with my girlfriend, who is hopefully going to be a nurse, and she actually just finished her nurse practitioner degree. So I know Nashville is a booming location for healthcare and a lot of opportunities. So both of us are very excited to get going here in Nashville.
Well, we're certainly really happy to have you guys here.
Well,
I hope it's everything that that you think it might be. It's a pretty great community. The state's a great community, and we need young, well-trained individuals to continue the name of TOA. So thanks for being here. So we're going to talk about minimally invasive spine surgery, right?
Yes, sir, yeah.
Okay.
So in terms of minimally invasive spine surgery, I'm sure, it's something that a lot of you have heard kind of being discussed, and as Dr. Stallman mentioned, it is, relatively new, I guess, in the perspective of spine surgery overall. But as he mentioned, it isn't something that's going to replace everything that's been, founded before. It really just builds off a lot of the same concepts and a lot of the same kind of fundamentals for the spine surgery that started even back in the 1800s. And as Dr. Stallman mentioned, a lot of that has just been founded or grounded in a lot of the advancements in technology and instrumentation that fortunately kind of has evolved, with spine surgery and with medicine in general. And so we've been able to utilize a lot of those techniques to do what is quote-unquote minimally invasive surgery, or less invasive surgery, should I say. So if in defining minimally invasive surgery, there's really a couple key points that I like to think about minimally invasive surgery. And the main real goal of minimally invasive surgery is the same thing as traditional open surgery. And that is something that's important to distinguish, is that when you speak about minimally invasive surgery, it's not like we're trying to reinvent the wheel. We're still trying to accomplish the same goal for the patient. It's just the way that we do it is going to be a little bit different. And the main thing that helps to differentiate kind of traditional open surgery with minimally invasive surgery is just the approach that we do it, where we try to essentially create as little damage to the surrounding tissues around the spine as possible. So in kind of, quote unquote old school or fundamental or traditional open surgery, it would involve kind of these big incisions where in order to access the spine, you had to move all the muscles away from the spine. And that would cause, unfortunately, just some, injury or damage to the muscles themselves as a nature of us just having to move them apart in order to actually see the spine. And with minimally invasive surgery, we, instead of trying to move those muscles apart, we work through them, or we work through kind of areas that maybe may not have as much muscle, as much tissue, in order to get down to the spine safely, and again, to accomplish those same goals. And that is really, making the patient better.
And so it's really been based on, we're doing the same end. It's a different means to the same end.
Exactly.
And one of the big things that I think helped us get that way is technology.
Mm-hmm.
We've made things smaller, more facile. We figured out that, big operations, even though there's a, scar in the skin, there's a lot of trauma that happens to the muscles and such that can cause problems down the road with regard to how your body functions. And minimally invasive does not mean non-invasive. Okay, that's an important distinction. We'll talk about that in a second.
Very true.
We're still doing surgery. We're still causing trauma. We're just trying to create less trauma
Exactly.
to the same area. What kind of advantages do you think some of the minimally invasive approaches offer, other than the trauma part, with regard to recovery?
So, again, going back to us kind of initiating or causing less damage to the surrounding tissues of the spine, that translates to less pain for the patient. It can translate to quicker recoveries, because not only are they recovering from the actual work that we're doing around the spine and the nerves and the bone, but then there's less work to be done and less recovery from the muscle standpoint. So the less pain, faster recovery, and then also the more that we know about some of these opioid medications and some of these pain medications that are being used, we've combined our surgery techniques with some of our anesthesia and pain techniques to essentially decrease the pain that a patient has, and thereby decreasing the amount of pain medications that a patient needs after the surgery, which is always one of our goals as well.
Awesome. So why don't you just march us through some of the things that minimally invasive techniques, what kinds of problems can they address?
So a lot of the same kind of problems that you may be seeing your physician or your surgeon for can be treated either with a traditional open technique and a minimally invasive technique. And one thing I want to reinforce is, again, as surgeons, we can't be a hammer and see everything as a nail. So we can't say everything can be treated by a minimally invasive technique. I think it's important to recognize for surgeons that there are some conditions, some people that will definitely benefit from just traditional open surgery. In terms of the things that we can address at present state with more of these minimally invasive or less invasive techniques, it's a lot of the same conditions. So disc herniations, stenosis or compression or narrowing of that spinal canal that causes compression of the nerves, instability of the spine, where the spine is moving back and forth, thereby causing compression of the nerves, doing different fusion techniques in cases that necessitate fusion. And then even in some cases, people that have curvatures of the spine or kind of altered positions of the spine, what we call spinal deformity, can be addressed by minimally invasive techniques. But that's still something that's definitely in the newer side and kind of new era. And a lot of that is still being done with traditional open techniques as well.
And as I understand, in the deformity side of things, many of the cases that are being done kind of currently are hybrid. So you do some parts of the case minimally invasively, and then some more of the traditional open. It's kind of a combo.
Exactly true. And so one of the things, the way that minimally invasive surgery has evolved over the past, let's say, 100 years even, as you mentioned, has been grounded in the technology. So with the invention of the microscope, in order to be able to do the surgery, we have to be able to see what we're doing. And that has always been one of the main advantages of open surgery, is that you can kind of move those muscles apart and look directly down at the spine, look at the nerves. And then before, when we didn't necessarily have the invention of microscopes, some of these new lighting technologies, some of the kind of even loop navigation that we wear on our eyes that can act as a replacement for the microscope, it was impossible to do because you couldn't necessarily see what you're doing. If you can't see what you're doing, you're not going to be able to safely do the surgery that you need to do. So a lot of the kind of the early advancements in minimally invasive surgery has been reliant on a lot of these technologies that allow us to actually see kind of not only what the pathology or the problem is, but then allow us to effectively treat that problem. And then additionally, in order to actually do it, we need the correct instrumentation. So, if you're looking at a screwdriver, you can't, screw a screw in with the wrong sort of screwdriver. And the same is true for surgery. You need the appropriate tools to be able to do what you're going to do, or do what you need to do, should I say. And so, kind of as a consequence that has followed from the advancements in technology for us to be able to see what we're doing, following that, we've now gained or evolved or developed the appropriate instrumentation that actually allows us to do it even when we can see it.
Right. That was my experience when I started doing some minimally invasive stuff a number of years ago. Was the tools that we have in our hands that we use to manipulate the spine were really designed for open surgery, and they got in the way. We're trying to see through smaller incisions and whatnot through different devices to try to hold the tissue apart, and the instrumentation wasn't quite matched to the visualization. And so the iterations of evolution of minimally invasive has allowed the surgeon to be able to see better, manipulate more kind of far away. If people have been experienced with general surgery, GYN surgery, urological surgery, the laparoscopic techniques through a scope and looking into the belly was revolutionary, and then the robotic technology on top of that, which is now fine manipulation with high magnification. Again, next iteration of technologies to allow safer, less invasive, not non-invasive, less invasive procedures that allow you to see better and manipulate in a finer way. We're really kind of following in their footsteps to some degree.
Exactly, and I'm actually, happy that you mentioned robotics, because that's essentially been something I'm sure a lot of our viewers have heard about, either in orthopedic surgery, spine surgery, and even other types of surgery, like you mentioned, urologic surgery or gynecologic surgery. And one of the big things I want to emphasize with robotics, it's a tool that we have in our arsenal, but it's not necessarily replacing us. So the robot, when someone says they're doing robotic surgery, the robot isn't actually doing the surgery. And I think that's a clear delineation that I want to make sure that all of you are aware of, is that when we emphasize we're doing robotic surgery, we are still doing the surgery as the surgeons. It's just a tool that we can use that can do it maybe less invasively and more safe.
And more precisely.
And more precise.
We actually had Will Carpenter on, who was demonstrating the Mako robot for doing knee replacements, and he actually demonstrated that. It was very cool. He's still doing the operation, but the device allows more precision and more repeatability.
Exactly.
And so there's definitely theoretical advantages to that.
Exactly. And then kind of with robotics, there's another concept that I'm a big proponent of, or another technology that I'm a big proponent of, and that is navigation. So in terms of kind of delineating or separating robotics versus navigation, when we talk about robotics, just similar to the Mako, there's a system in place that acts almost as like a robotic arm. It's something that you can work through, you can work with, but when you do navigation, it relies on the same technology, so you still need to be able to see, you still need that same imaging, but in order to kind of do the navigation surgery, it just gives you another kind of perspective or another visualization of the spine that you may not be able to have just by looking at the spine itself.
So tell me a little bit about if somebody comes into your office and they have whatever problem it is, how do you decide if they're an appropriate candidate for a minimally invasive approach, or you'd rather do an open approach? What are some of the factors involved in that?
So I think, when deciding in terms of doing a minimally invasive approach or an open approach, part of it is the first consideration is, I have to think, am I going to be able to accomplish the goals of surgery, which is addressing whatever problem they may have and then getting them and restoring function. And then the second question is, can I do that safely? And when deciding, a minimally invasive style approach or more of a traditional open approach, a lot of times it possibly is dependent on a patient's anatomy, the way that their spine sits. It's a question of where that problem is. We have to know that minimally invasive surgery isn't the catch-all be-all for across, treating spine conditions. So it does have limitations, and you have to recognize those limitations in order to be, in order to apply kind of that technology appropriately. So certain things that I look for is, again, what the problem is, where the problem is, and then a lot of the times too, with minimally invasive surgery, it can be done through a smaller incision, but if it's a problem that has to be addressed at kind of multiple different areas or multiple different locations, rather than doing separate smaller incisions in these almost kind of separate procedures, is it something that can actually be done more effectively, quickly, and safely just by doing one kind of longer, more traditional style surgery?
Yeah. Are there any patient factors, anything about a patient that might lead you to believe from a technical standpoint, I can't really do a minimally invasive approach if it's potentially a problem that's minimally invasive treatable? Are there patient factors? And I'm thinking of everything from infection, cancer, obesity, whatever that might change your way of thinking. Are there patient factors that kind of run up against the capabilities of MIS?
So there are certain things that I would still kind of address from a traditional open kind of standpoint. One of them is, you mentioned cancer. When you're doing a cancer procedure, it usually requires a little bit more extensive work just because of the nature of the cancer itself and the way that cancer can affect the surrounding tissue. So in order to be able to adequately treat that cancer, I don't know if it's necessary. In some cases, yes, but in all cases, I don't necessarily know or think that it can be done necessarily through kind of a minimally invasive small approach. Because again, one of the difficulties with minimally invasive surgery, like we touched upon, is being able to actually see. So if the problem, is, especially with cancer, that can sometimes be a little bit, a larger of an issue or larger of a problem, just the pure visualization alone, I don't know if it's necessarily appropriate to do it when you can't actually see and can't actually address the entirety of that cancer, for example. And then other patient factors is, patients that may have a little bit more soft tissue, in order to do an open procedure, you would have to move all of that tissue away, and sometimes that requires doing an even bigger procedure in order to address the same problem, because you end up working kind of down this small little kind of tunnel. And rather than doing that, we can actually, in those cases, I prefer actually doing more of a minimally invasive approach, because rather than doing these big incisions to work on a small problem, I can do a small incision to work on that same small problem, just because it gives me more direct access. And that's kind of one of the concepts too, or one of the fundamentals or pillars of minimally invasive surgery, is that a lot of it is dependent on access. So you want to be able to access the area that you need to work on safely and effectively, and sometimes from an open procedure that just requires a lot more work, kind of more superficial.
That makes a lot of sense. What are the kind of negatives to minimally invasive surgery? I mean, every surgical procedure or technique has pros and cons. What are some of the cons of minimally invasive surgery techniques in general?
So I think with minimally invasive surgery, again, being a relatively new kind of mentality to think about spine surgery, there is a learning curve with minimally invasive techniques, and that is especially true for maybe someone that is used to more of these traditional open procedures, because it is reliant, again, on some of these newer technologies. It's reliant on radiographs and x-rays in the operating room in order to be able to see, since you can't kind of open up and expose and look at the entire spine. You're more reliant on x-rays and different imaging techniques to see and pinpoint exactly where you are. So I think that is definitely one kind of downside, is that there is a learning curve in order to learn these techniques.
Now, you're at an advantage here because basically throughout your training, these techniques have become relatively standardized, if not standardized, and so they're just part of your training. If someone like me Now, I've learned about this stuff over the years, but if someone like me had never done something like this, the learning curve really applies because it's completely foreign in many ways of how you move your hands and move your eyes and where to look and how to see the pictures and whatnot compared to what we've done for so many years. And so you're at a big advantage over somebody who's trying to learn it after a big long career of doing open surgery.
And that is very true. You know, I am very fortunate to have trained in some institutions and some programs where the pioneers for minimally invasive surgery are working.
Right.
So I was able to learn from the people that kind of invented the minimally invasive surgery, developed it, and then saw kind of the pitfalls and, you know, some of the potential benefits. And so I was able to take, you know, their 30 plus years of experience and apply that to what I've learned and then apply that to my own practice.
Right, right. So you're really a leg up on a lot of people like us. Being old is old. Anything else that's kind of a negative to minimally invasive techniques? I mean, so for example, we know that there's a certain risk of infection. There's a certain risk of injury to the tissues that you don't want to injure, such as the nerves or the dura, things like that in the spine. Are minimally invasive techniques as safe, meaning the same risk profile as open techniques? Are there situations where it's actually complications actually occur more frequently, that type of thing?
So it's actually a benefit of minimally invasive surgery is that their complication profile or the risks associated with minimally invasive surgery are actually traditionally less than, or the risk of minimally invasive surgery are less than traditional open surgery. So that includes things like infection, that includes things like blood loss or losing blood during the surgery. You know, I think really two of the main kind of downsides of minimally invasive surgery at this point is, again, because you have a limited ability to see or kind of experience or explore the area that you're working on, if you do run into a complication, let's say there's an injury to the nerve sac, then sometimes it can be more difficult to address that, again, because you're working through a smaller channel or a smaller opening. And you know, a second kind of downside of minimally invasive surgery is I think oftentimes people will try to do something minimally invasive and then not address the problems that they were necessarily trying to address. And I think with open surgery, it's much easier since you can see everything to address exactly what you're trying to address, to treat the problem and to, again, restore the function. So in some cases, especially, again, early on as people are learning these techniques, they may not accomplish all of the goals that they're trying to accomplish just based on the techniques themselves. And then a third thing, especially for some of us younger surgeons, you know, as I mentioned, we are very reliant on radiographs, CAT scans, and different imaging techniques in order to be able to see and effectively do the surgery. But with that comes the risk of radiation exposure. And if you add that up over a lifetime, you know, I'm kind of a younger surgeon in practice, so I hope to have many more years. And that radiation can take a toll. You know, obviously, the more we know about the radiation exposure, the more we know not only for the patient, for ourselves, for the team in our operating room. Everyone there is being exposed to that same radiation, and so that's something that we'll have to consider. And I think that's actually one of the things that some of these emerging techniques are trying to improve upon, is decreasing the amount of radiation that the patient has, that we have, and that our team has.
Right, increasing the safety profile of the procedure in general.
Exactly.
I mean, that really makes a ton of sense. And frankly, you know, one thing that minimally invasive techniques have is that for the most part, if you get in the weeds and you can't see what you need to do, you can always default to an open procedure.
Exactly.
You have a backup plan that is you're still versed in. I mean, it's not like you only do minimally invasive procedures. That's an add-on to the basic tenets of spine surgery, but you have a bailout.
Exactly.
And so you don't like to go that way if you don't want to. I think some surgeons kind of get too wound up in it's got to be done minimally invasively, and that can be a detriment in some cases because they can't get everything they need to do, and so you have a bailout.
Exactly.
And that's very, very appropriate to do.
And that's kind of what I was mentioning before, is being a surgeon, you know, you can't be the hammer and see every problem as the nail, saying every problem I'm going to do minimally invasive, regardless of what's happening elsewhere, regardless of the other factors. I think minimally invasive surgery is a very good, useful, safe, and effective tool to have in your arsenal, but it's just that. It's one tool that we have as surgeons to accomplish our goals.
Yeah, I think that's a big thing. In my observation, in any type of surgery, people who kind of pigeonhole themselves into one thing and you know, factors be damned, I'm going to do it this way, are missing an opportunity to just add to their toolbox.
Exactly, because at the end of the day, we are trying to get the patients better, and we're just trying to do it as effectively and as safely as possible, whether that's minimally invasive techniques, whether that's more traditional techniques. I think it's just something that we continue to build upon in order to really do what we're here to do, and that is to get the patient better.
So we've talked about navigation, which is a big part of one of your tools. We've
Mm-hmm.
talked about the minimally invasive techniques, the tools, the exposure techniques and whatnot as part of your situation. We've talked about augmenting or adding robotic types of tools. Are there any things in the future that you see on the horizon that might add to the mix that's kind of minimally invasive surgery 2.0 or 3.0 probably is what we should probably call it?
There's something that I've had the very fortunate experience of having early exposure to in my training, and that is actually augmented reality. So when I'm saying augmented reality, kind of people think about this virtual reality setting where you're looking and what you're seeing isn't actually real life, it may be something else. But augmented reality is you're using kind of that same technology, but applying it, kind of in a real world situation. So in the situation with augmented reality in spine surgery, what we can do is we can actually look at a patient, look at their spine, and without even having any imaging, without seeing the actual bones or the tissues or the nerves themselves, we can actually look through kind of these glasses or whatever technology is associated with that augmented platform and see the spine without having to make any sort of incision, without having to make any sort of cut, and that makes us that much more effective in getting to where we need to go.
So that's utilizing pre-obtained data,
Exactly.
correct, to be then overlaid upon the actual physical view. So it's a virtual view on top of a physical view. Is that right?
Exactly.
That's very awesome. And that's what the military uses in the F-22 and F-35. But
Exactly. Exactly.
hopefully we don't have a $450,000 helmet to use.
No.
But that's an incredibly useful tool because, as you said, for example, tumor, open surgery is oftentimes the preferred approach because you want to see what's going on around that you may not be able to see on an x-ray or whatnot.
Mm-hmm.
And that may give you the opportunity to do a tissue-sparing operation, but actually take care of the problem more effectively. So that's really exciting.
Yes.
Really exciting.
And then there's also another technique that's really picked up momentum. It's actually something that was developed in probably the 1840s to 1860s, but that's endoscopic surgery. And so with endoscopic surgery, it's something that some of the patients or some of our viewers may have also heard about because it is, picking up momentum in terms of the spine surgeon community, especially within the past probably about 10 years or so. And when people talk about endoscopic, they may refer to it as ultra minimally invasive surgery. And that's just because it can be done through even a little bit of a smaller incision. The difference between the incision for endoscopic surgery and then traditional minimally invasive surgery probably isn't that significant, but what it relies on is it combines a lot of the previous technology that we've used in other parts of orthopedics, such as arthroscopy, when people are getting arthroscopy in their knee or arthroscopy in their hips, even arthroscopy in the ankles. And what it does is it allows the use of a camera with a built-in kind of channel for instrumentation to be done even in a smaller surgical footprint with even less damage to the surrounding tissue.
Yeah, and that's a good point because still with the standardized minimally invasive techniques that you're using, you're relying upon your eyes
Mm-hmm.
or your magnified vision with either magnifying glasses called loupes or the microscope and imaging.
Exactly.
Whereas that is strictly you're looking at a television screen at a camera projection,
Mm-hmm.
so they can make the tool smaller and more magnified, and you're not relying on your human eyeballs to do everything. The magnification is phenomenal. That's the whole situation in arthroscopy, laparoscopy, and robotic types of general surgery tools, which are laparoscopic tools with much more magnification and better tools.
Exactly.
Very cool.
And so people may have heard about like 4K televisions, which is kind of the big thing right now for televisions. So they've been able to apply some of that same technology with the instrumentations and the cameras that we're using during surgery to get an even more clear picture of what we're doing.
Awesome. Awesome. Yeah, somebody tried to sell me an 8K television.
Oh, I didn't even hear about that. I
Wow,
didn't even know that
8K.
existed.
Who would know? Who would know? Anyway, well, awesome. Let's stop there. I think that's probably a good thing. Before we finish off, how do people find you? For example, where are you in office? Which locations and what days? So if somebody wants to see you for their spine problem, how do they get to see you?
So I'm primarily working out of the Murfreesboro office right now. Appointments can be scheduled via telephone, and then we're working on an electronic appointment system so that they can schedule appointments online, which will just make it that much easier for people to get access and to get into the office. As of right now, I'm primarily seeing patients on Mondays, Tuesdays, and Thursdays. And really I'm happy to see anyone for any sort of spine problem, pretty much from the base of the, kind of the head all the way down to the tailbone. So if anyone has any conditions, I'm always more happy than
Awesome.
to see people.
Awesome. Well, I'm so glad you're here. I was impressed with you when we interviewed, and I was so glad when you accepted our offer. And I'm hopeful that we can provide you with a really, really enjoyable, fruitful career. And like I've told you before, if you need me, I'm here for you.
Well, I'm so excited to be here. Very excited to have the opportunity to work at TOA, and again to be part of this Middle Tennessee community.
Well, this is a huge deal for TOA. As Whitney Houston said, the children are our future. He's not a child. The younger people, new blood is a good thing for medical care. And Nick offers things that pretty much almost all of the spine surgeons in TOA don't offer. Dr. Shibiyama offers, I would say, a subset of what you offer.
Yeah, we both trained at the same place. We have a very similar background.
Similar backgrounds.
Yeah.
He's kind of niched himself a little bit. He's a little bit older, but now we have two people who are minimally invasive surgeons, as well as great open spine surgeons. So our opportunities to try to help Middle Tennessee and beyond have just gotten better. So anyway, I think we'll wrap it up today. We are not going to be here next week and the following week. But the following week after that, so 3 weeks from now, Anita Slaughter is going to be back. Anita is owner of A-Train Fitness, and she's one of the consultants and administrators to TOA Sports Performance Center. And we're going to be talking about certifications of personal trainers. How do you vet a training partner by various certifications, training, etc.? There's a lot of letters related to personal trainer certification, and Anita's going to kind of help us wade through that so you can understand what you're talking about when you try to interview or hire a trainer for yourself or your family. So with that, stay safe, be healthy, get your vaccination, please. It saves lives. There are people dying in the hospital that are unvaccinated that shouldn't be there, my opinion. Anyway, see you in a few weeks. Have a great weekend. Go out there, live your best life. Take care, everybody.
Thanks, guys.